All right, good morning, everyone. Welcome to the CAT-Lab number 2 of the number 1 hospital of Harbin Medical University. And today is just the transmission for the routine case. There's no specific theme. As usual, the introduction of my colleagues first. Dr. Gong Yongtai is the first operator. Dr. Zhao Ji, Dr. Sun Danghui, Dr. Li Tiankai, Dr. Wang Dingyu are the rest operators. My name is Li Jianqiang. I'm the moderator. So Dr. Zhao will introduce the case first. Dr. Zhao, please.
Good morning, everyone. I'm Zhao Ji. Before the operation leaving broadcast, I would like to make a brief introduction about our patient first. This patient is a 62-year-old male whose chief complaint is paroxysm, chest pain for 4 years. The main risk factor of his disease is hypertension. His echocardiogram showed an ejection fraction of 68% with no motional abnormalities. The electrocardiogram showed sinus rhythm and no TV inverted and ST segment depression. The prior coronary angiography showed that there was a severe stenosis in the proximal LCS, but the patient refused PCI. 2 years later, in another hospital, angiography revealed total occlusion of proximal LCS, receiving both collateral from LAD and RCA via PLV branch. Next. The patient underwent a field CTO PCI with an anterograde approach, but where did not enter into true lumen. Next. And then we have performed a CTA scan on the patient, and the results showed that the occlusion length is very long, more than 20 millimeters, with no calcification. In order to understand the coronary artery lesion deeply, the intelligent visualization system for CTA invented by Professor Li Yue in our hospital would help us to get more information. Please, Professor Li Tiankai, introduce this part.
Yeah, the 3D reconstruction image shows there are two occluded part in the LCS. One is in the proximal and the other is distal part. The distal part is relatively long and without calcifications. That's all.
Thank you.
All right. I think today we have a very interesting case, and this is a very sorry. This is a very typical circumflex CTO. And from the CT angiography, we don't see severe calcification. So according to anatomy of this lesion, I think it's a GCT score 2 C2 lesion. So Dr. Gong, so we have enough information about this lesion. What's your strategy?
Okay. For this video leading, as we know, the important baseline step is the dual injection and CTA scan, and both these steps will give me a lot of information. Firstly, from the CTA from the CTA from result, we can find the proximal cap located just the bifurcation, and from the angiography, we can see the tapered proximal cape, and according to the proximal cape, the shaping of the proximal cape, we can choose the appropriate Y to advancing the occlusion segment. Next important step is the dual injection. As shown in this case, from the dual injection, we can see that the RCA oriented from RCA, there are several epicardium collaterals, but it's very small and is not visible continuous. For this patient, the antegrade approach is our first choice, and if the Y entered the true distal true lumen, of course, this is the fortunately a result and a good result. We will quickly finish the case. Otherwise, if the Y entered the subintimal space, as we know the extra plaque, then we will perform the re-entry technique. As we know, there are two re-entry techniques include based Y, such as the last technique, or based dedicated equipment, as we know the Stingray balloon. So, firstly, we and okay, the next.
All right, so based on the anatomy of this lesion, because we can see a tapered proximal cap, and the condition of the contralateral is not that good, so the antegrade approach is preferred, right? As you mentioned, we could do the antegrade wearing technique. If the wear goes into subintimal, we can do the ADR, right?
Yes.
So, but before actually we did the avastron, right, in the OM to see the proximal cap of the circumflex. Can we show the audience the avastron?
Okay. For this patient, intravascular image is also important to help us to find the location of the proximal cap and to confirm the location. So we performed IVAS pullback from OM to find the and to confirm the location of the proximal cap as just we just we understand the information. Okay, next the next theory.
Maybe we can see the avas image first. No?
Okay, from this theory we can see this is OM lumen, and from distal to the proximal, there are very okay.
Here comes the circumflex.
This is the main branch, the proximal cap of the occlusion segment. Of course, we found there are several significant stenosis at the proximal segment of OM from the AVAS image.
So after the AVAS, I think we have a better understanding of the anatomy of the circumflex occlusion lesion. So because there's a taped cap, what's your wear choose? What kind of wear you choose to penetrate the proximal cap?
Yes. According to the different different shaping or different different shaping of the proximal cap, and there are different choice of the first Y. As we know, for the tapered proximal cap, usually we choose a softer tapered tape and with a polymer jacketed Y. For this case, we choose field XTY for the first choice. Next, under the dual lumen micro capture assistant the field XTY was advanced and successfully entered the segment of occlusion. Then we carefully to manuate the chart of the Y and successfully across the segment of occlusion.
So when you try to deliver the wire, it didn't feel much of the resistance, right? It's kind of easy.
When we encounter the resistance, next step, we exchanged the KDL, that is the dual lumen micro catheter, to the Cosiac micro catheter to enter the segment, occlusion segment, to give the Y more support and enhance the penetration force of the Y.
So when you deliver the wire, you did feel a little bit resistance, and that's why you exchanged the dual lumen catheter with the macro catheter, the Corsair, right?
Yes.
To increase the backup. And then after the use of Corsair, I think the wire was kind of easily to be delivered to the distal part of circumflex.
And yes, the distal Y location is very important. This should be confirmed by the collateral injection or collateral angiography. For this case, after confirmation of the location of the distal Y, we found it located in the distal true lumen. Then we advanced the micro catheter to the distal segment and performed tip injection to confirm the true lumen again. In some cases, the Y entered the extraplex space or the intimal space, and then we will perform ADR technique, that is antegrade dissection and reattempt technique. But fortunately, for this patient, we performed a Y advancing across the occlusion segment successfully to the distal lumen, true lumen. After prodilatation, next we will perform IVAS imaging and to help us to the next PCI step. For example, the DB or DS.
So I think today we were very lucky, right? So we put the wear into the true lumen. So we were very lucky. And I think, after the wear was delivered, when you try to deliver the macro catheter over the wear, you did feel a little bit resistance. And then you use some small balloon to dilate first. And then, for the rest of this procedure, kind of easy to deliver the macro catheter over the guide wear.
Yes.
Yeah.
Small balloon dilatation help to advancing the microcatheter.
Hmm.
Of course, if during the process we found the Y and not located in the distal true lumen,
Hmm.
and we will quickly exchange the stingray balloon
Hmm.
and perform the ADR
Hmm.
technique.
Yeah. So as a CTO operator, I think it's very important to switch strategy based on the situation.
Yes.
Yeah. So Judge Gong, there, how many methods can be used to confirm the position of the wear in the distal lumen, whether it's intraplug or extraplug?
Okay.
Yeah.
Uh,
Like you mentioned, we can do the tip injection to confirm that. Any other methods we could use?
yes. The most widely used technique, of course, is the collateral injection or collateral angiography.
Mm-hmm.
This is very simple and safe technique. Uh, another another technique is the Y can freely enter the assigned branch of the distal target vessel. This is also a sign of uh, the Y entering the true lumen. Uh, uh, Other technique include the tip injection, but it should be carefully before injecting the contrast. We should as per the blood from the microcatheter
Mm-hmm.
to confirm that the microcatheter may be
Mm-hmm.
in the architecture, the vessel architecture.
Mm-hmm.
Of if the micro advanced out the vessel architecture, if you perform the tip injection, it will uh, induce a large perforation and it's a large
There,
complication.
you're right.
Another technique including the IVAS imaging to confirm the location of the distal Y.
Mm-hmm.
But it can cause extension of the dissection and maybe induce large hematoma.
Mm-hmm.
Okay.
So while we will perform the tip injection, we have to be very careful. It could may how to say may aggravate if it's in the subintimal. It may aggravate the dissection. If it's outside of the architecture, it may increase the perforation.
Yes.
So right now you are trying to pre-dilate the lesion, right?
Yes. For this patient, if the first Y we choose failure to cross the segment, next we will perform anti-grade Y es escalation
Mm-hmm.
and increased the stiffness of the tape of the Y and uh, according to the cause of the target vessel.
Mm-hmm.
If the cause is very understood by us, we can use stiffer and tapered tape. If we cannot understand the cause well, we will use a not tapered tape. We use a polymer jacketed wire.
Mhm. So when we try to penetrate the CTO with the Anterograde approach, maybe we exchange the wires very often depending on the lesion situation. Sometimes we use the tapered wire, sometimes we use a hot wire. It really depends on the anatomy of the lesion.
Yes. Both the technique and the strategy switch is very important for CTO recanalization.
Mhm.
Okay.
For some beginners, when they try to deal with the situ lesions, once they how to say reopen the occlusory segment, they think the rest of the procedure is just a piece of cake. But Dr. Gong, can you share with us, after recanalize the situ lesion, what are the tips, or tricks we had to be aware of? It's not like, after we reopen the occlusory segment, the rest of this procedure is kind of easy. It's not like that. So something we had to be aware of.
Okay. For now we want to look at the intravascular
yeah.
image firstly, then we will answer your question. Okay.
Mhm.
You feel leaving. Huh?
Mhm.
I think there are no optimal landing zone for
Mhm.
stenting
Mhm.
because of the diffuse plaque burden.
Mhm. The lesion is kind of diffused, but I think the plaque is kind of fibrous. It's
Yeah.
not calcified plaque,
Yes.
but there's no good spot to land the stents.
Yes.
And then what's next?
I think DB may be a good choice.
Mm-hmm.
And next we will pre a dilation the lesion again
Mm-hmm.
with a cutting balloon.
Mm-hmm.
According to the IVAS result, we can give a little contrast injection, just slowly.
Mm-hmm.
Okay, it's very good.
So before the use of DEB, I think the pre-treatment is super important. We have to well pre-treat the lesion first, and then the DEB can be well expanded, and then the drug can be released into the vessel wall.
Yes. The okay, collateral injection to confirm the donor vessel not be injured, and then we will put down. We will put back a little injection. Okay, it's very good.
Dr. Zhao, actually, this patient was hospitalized in another hospital about 2 years ago, and the circumflex was occluded back then already. And some doctor, they tried to recanalize the situ lesion, but they failed. What do you think could be the reason why they failed for the first time?
Nurse.
2 years ago,
Mm-hmm.
this patient in another hospital
Mm-hmm.
received are CTO PCI,
Mhm.
but CTO PCI is a field.
Mhm.
Maybe the first CTO were advanced into the internal space of the fourth Luren.
Mhm. Mhm. Maybe the first operator he didn't have much experience with the ADR or some other techniques. So once they found the wire was into the subintimal, they just stopped the procedure.
Repeat the intravascular image again.
Mhm.
We will choose the appropriate size cutting balloon.
Yeah. Can we review the Avas image?
2.5. Just 2.0. Next, 2.5.
3.4。背一个这个，这样拿一个。
2.0 in the distal parts.
Yes, it's
And-
very small,
Mhm.
but 2.0. But the location from the location to the proximal
Mhm.
location is very large.
Mhm.
1, 2, 3, 4, about 3.5 millimeter. The diameter of the segment.
Mhm. So how many dBs will be needed?
Maybe 2.
Mhm.
Okay. Let's give me a 2.5 cutting balloon.
2.5，2.5。
So because the plaque is kind of fibrous, that's why you choose the cutting balloon to pre-treat the lesion, right?
Yes, they are very heavy,
Mhm.
like a burden
Mhm.
with
No,
fibrotic.
2.5. 2.25 or 2.
2.25. Okay.
2.25。
225 is also okay. So in terms of the pre-treatment of this lesion, do you think there's a difference between the cutting balloon and scoring balloon? Is this scoring balloon is also okay for this lesion?
Yes. In fact, cutting balloon and other scoring balloon, it's also
Mhm.
have the same efficiency to pre-dilate the fibro plaque lesion.
So either of these two tools will be fine for this lesion. It's just a personal preference. You may have more experience with the use of cutting balloon. Dr. Zhao, when people deal with the CTO lesion, when they try to use the integrate approach, so sometimes if the first wire goes into the subintimal, they may use the parallel wiring technique. So can you share with us about that technique?
Yeah. The parallel wiring is a very useful method in the CTO PCI, especially in the Anterograde CTO PCI. The parallel wiring technique allows the operation to keep the first wire, which has gone into the subintimal space into the distal cap, as a marker where a second wire can modulate into the true lumen and guided by the position of the first wire. This technique have just 3 obvious advantage. The first is the user contrast to locate the position of the distal true lumen can be reduced due to relying on the position of the first wire. The second advantage of the parallel wiring technique is the first wire can act as a rail to guide the delivery of the second wire into the CTO body. The second advantage of the parallel wiring technique is the existence of the first wire reduced the risk of the higher penetration wire going outside the vessel during the using through the CTO body by acting as a indicator of the vessel cost. Thank you.
Yeah, I think the parallel wiring technique is one of the commonly used anti-grid techniques. So thank you so much for the sharing. I think that's very important for some beginners. So Dr. Gong, after the use of cutting balloon, you will use some NC balloon for further dilatation?
Yes, after NC balloon dilatation, we will perform intravascular imaging again to help us help us deciding the next DB or DIS. Both a good choice.
You haven't decided yet, right?
Yeah.
It could be DB or it could be DS.
Yeah.
Dr. Gong, here is Jingyu. There are some questions from the audience online to you. The first of all, they want to know, are there any techniques or tools that help you to improve the effectiveness of anti-grid approach this time? I know Professor George just talked about it, but they want to know your opinion. Professor Gong?
Okay. For this patient, of course, the case is very suitable for the antegrade to recanalize the CTO's lesion because the epicardial collateral is very poor according to the size and the continuous. And the antegrade one, as we know, includes several techniques, including the antegrade Y escalation and parallel wiring and ADR technique. Both can be used during according to the first Y, the location of the first Y distal.
Maybe I think the audience wants to know why you were so lucky, just to get the wire into the true lumen. It's
Okay,
just
no,
because of the lesion, or it's because you have so much experience.
Okay, it's not lucky. We just based on the CTA analysis and the angiography analysis carefully. Another important, I think we should choose the perfect strategy and technique according to the experience from the textbook and we the technology and the technique both let us can repeat it successfully.
Yeah. Again, I think for the treatments of situ lesions, the pre-operation evaluation is super important. We have to review the previous angiography. We have to review the CT angiography images, and both imaging can provide us a lot of detailed information about the situation, and then we can choose our strategy.
Yes. In fact, after predilation,
Mm-hmm.
from the angiography, we can see the team of the occlusion segment is successfully recanalized,
Mm-hmm.
and there are no significant dissection. So the IVAS
Yeah.
image will perform again.
Mm-hmm.
Okay. It's maybe a good location. Very good.
Yeah, it looks fine.
Student.
Mm.
Student is also a
Yeah, after
very
the
large.
after the pre-treatment, I think it's okay to put stents.
Yeah.
At the B.
A little dissection,
Mm-hmm.
which may be caused by our
Typing balloon.
balloon.
Mm-hmm. But it's not significant.
Yes, then the stent will be placed here. Okay.
I think for this lesion, if we
Manually.
could put stents, and this patient may benefit more from
Yeah.
stenting.
Dr. Wang,
I'm here.
can you review the image?
Okay.
1, 2.
We can see
Oh,
the vessel is
2.5?
much larger. And
2.5. It's okay.
2.5 or 3.0?
2.5.
2.5.
Okay. Dr. Wang, we will perform intravascular imaging again.
again, okay.
Manually. Okay. We just
Okay, manually, yeah.
yeah.
Okay. Can we start now?
Yes. It's okay. Give me a little contrast. Oh no. Okay. Okay. The longest 2.5 stent.
So how long is the stent? How long is the first stent?
The longest.
The longest?
Yeah.
38?
2.5.
Yeah. Okay. Review the imaging. No. Left. Okay. It's about here. Okay.
And Professor Gong, another question from the audience online. When will you remove the guide wires from the RCA and the LAD? When will you remove the guide wires?
Which guide wire?
The guide wire in the RCA and also in the LAD.
For RCA, I think after the CTO segment was successfully recanalized and the collateral injection cannot be used, we will remove the collateral, the donor vessel guide wire. Give me a little contrast. Okay, that's
Yeah, I think, after the stent implantation,
little contrast.
the contralateral injection is not needed, and then the guide wire in the RCA could be removed.
It's okay. A little contrast. Okay, just we can pull back, quick. Okay. A little contrast. Okay. Okay. Nah.
Dr. Gong, another question about the guide wire in LED. When you will remove the guide wire in LED?
For this patient, the LADY can give me another additional support to make the inter-system more supportive.
Yeah. Because right now the guide wire in LED can stabilize the guiding catheter in the left corner system.
Yes.
And then it can give you more backup.
Yeah. And the guide wire will be removed after the finish the entire